So, first of all, thank you to Smile Train to inviting me here. I feel very honored and privileged to be here. So today, I'm going to talk about the psychological consideration for individuals with cleft lip and palate. More specifically, you're going to walk away today with an understanding what is body image, why do individuals with visible differences often face stigmatization, the psychosocial consequences, and what should clinicians say or not say in relation to psychosocial aspects when engaging with your patient. So, as you know, we're all living in an appearance-focused society, and young people regular comparison between themselves and others based on appearance and other characteristics. But body image awareness becomes even more prominent, and early adolescence is a particularly vulnerable period. But the reason is that body dissatisfaction in the general population is relatively common, and it's estimated about 2/3 of children and adults are not satisfied with their body image. I could ask you in the audience, are you satisfied with how you look and feel this morning? Maybe depending how late you were out. But what is then body image that we talk so much? How do we view ourselves? So there's 4 components to body image. One is the perceptual one, how we view our bodies, the reactions we feel when we look at ourselves in the mirror. We see our reflection. That can generate positive or negative aspects. And that leads us to the cognitive part, how we start thinking about our body, how I look. And that process leads us to the behavioral component, how we behave in relation to our body. For example, if I feel I'm not looking so good today and so on, I'm useless, I might opt not go to work or school. That's a behavioral response. And then we have an affective one, the emotional one, that can influence you very considerably. So those 4 components is what makes up body image. And I think that's really important to consider throughout this lecture. And we know that one group that might be more prone to poor appearance satisfaction are those with a visible difference, such as cleft lip and palate, for example. Research has shown that in individuals with cleft, as we progress from a young age to adolescence and young adulthood, their appearance satisfaction decreases. They're not as pleased with their appearance. This decrease in appearance satisfaction can result in emotional and social difficulties. In contrast, we can also experience stigmatization. So what is stigma then? It is when someone is stigmatized, they're often perceived as inferior, abnormal, or undesirable by others in the society. And stigma can be directed towards various aspects, such as physical appearance, health conditions, mental health, disability, race, gender identity, sexual orientation, or socioeconomic status. And we know that those with facial difference, which refers to a face that looks noticeably different from what people typically expect from a normal human face, often, but not always, feel that they are stigmatized. And this includes our group with cleft lip and palate. And then one risk factor, for example, that contributes to poor psychosocial outcomes for individuals with cleft is if they are being teased or bullied based upon their condition. And teased and bullying can occur in schools, but also occurs in their home environment, in the workplaces, and so on. And you can imagine then, if you are being teased or bullied, getting negative comments about your appearance, how that influences your body image. The 4 components you know what are. So we know from the general population that poor body image is a risk factor for low self-esteem, depression, depressive symptoms, anxiety disorders, and anxiety symptoms, risky health behaviors like drinking, smoking, and so on, and impairment of quality of life. And this is the general population. Then take in consideration your patients. It has a visible difference in how we cope, depending. This leads us also to the question about mental health in relation to individuals with cleft. And there's quite a few studies on population-based studies that shows there's in our population with cleft an increased risk for behavioral problems, increased risk for psychiatric and neurodevelopmental disorders. Two big studies in Denmark and Sweden showed that individuals with cleft have a higher prescription rate of psychotropic medication in relation to the general population. In those countries, to be prescribed that kind of medication, you have a clinical diagnosis. So we know there's a higher risk for this, but we don't know why in reality. It's most likely multifactorial. And that then leads us, how do we create good psychosocial outcomes? How do you, in this room, when you work with your patients, how do you create a good psychosocial outcome for them? Because that is really important. And I'm going to give you some tips and hints about this and some things to consider. So, for the majority of health professionals, like you are, the primary aim of care is to improve or optimize the patient's quality of life. We can all agree upon that. That's one reason I love working with you in this cleft community. You're all so passionate to strive to do better and help the patients. But most believe this is best achieved through striving to produce the best possible aesthetic and functional outcomes. And of course, that is important. But this may lead to be enthusiastic about the potential of repeated or new treatments. Sometimes perhaps in the high-income group, a risk for over-treatment, to doing new, some we spoke about yesterday. So what does the patient say then? This is based from a European project. And with some quotes, my parents and the doctor always talked about what my surgery would do. They did not warn me about how I would feel or how I could face people at school. Or, if I had known what was to come, I would probably not have bothered with the surgery at all. I felt misled. I had a jaw destruction when what I really longed for was to get rid of my lip scar. I would like to have more time in a different, less clinical environment to ask questions. So when you look at this quote compared to what we healthcare professionals want to achieve, there's some discrepancy. And this leads us to the aspect of being objective versus the subjective. So when we look at objective and subjective ratings, and this is a quite old study, but it's a very good study. In this study, they had 400 participants from plastic and reconstructive surgery patients. Of them, 217 were rated objectively by the surgeons, so they looked at them and gave them a score. And 183 of them rated themselves subjectively, how they felt about their appearance when they looked in the mirror. So when you looked at the surgeon-assessed severity rating of appearance differences, what the surgeon scored and guessed if they would have any problems with the well-being, it did not predict well-being at all. In other words, when you look at the patient, you cannot predict how bad or good they feel. What did make a big difference is the self-assessed severity ratings of appearance differences, the individual themselves, and that does predict well-being. So, in other words, how different a person thinks he, she looks has a bearing on how the person feels. How different a person actually looks says nothing about how the person feels. I worked with patients with head and neck cancer that lost almost half their face, and they go out in society, they're engaging, they're active. Then I have colleagues who are cleft lip, minor scar on the lip, clinical depression, isolating themselves at home. So severity has nothing to do with it, or gender, or age. It is the subjective appearance, how they feel about yourself. And as you as clinician, you need to keep that in mind because you're very technical. You're brilliant in your surgery, orthodontics, how that works, and even speech, how you talk. Because in speech, if you feel bad about yourself, you speak with nasality. That will also influence how you communicate. And we know the less you communicate with people, the worse you feel about yourself as well. So it's not just about the millimeters to right or left, it's about the person's feelings. So what we need to do is making care more person-centered. We need to look at each individual because we know that positive adjustment to a visible difference, such as cleft lip and palate, is better predicted by psychosocial factors than by aesthetic and functional outcomes. Ideally, psychological care should be available as a matter of routine. This doesn't mean that you need to have a clinical psychologist on your team with you, because this should be a team responsibility. Everybody in your team should have this ethos and be able to talk about that. And it's not difficult to learn at all. And we need to take a normalizing approach to providing care. So the condition, or this case cleft, it will affect over the lifespan. For example, I mentioned earlier, when we go from being younger to young adulthood, adolescence, they've been more aware of their appearance. Of course we are. That's this time, for example, romantic relationships starting, finding out their way, and looking different in a very appearance-focused society is difficult. So we need to take in the cultural context in our society, but we also need to take in the social determinants, which I speak a lot about, because you can't have the same approach for somebody who comes from a high, well-educated family versus someone who comes from poverty. We need to adopt our approach, which I know you do, but it's very important to keep that in mind. And then it is the individual, the interpersonal factors. Each individual are different. In order to get good outcomes or good patient rapport, being person-centered, we need to talk to them to find out what they want. And in some cases, there is the condition-specific issues. As I mentioned with research, that there are a higher risk for psychiatric and mental health problems in our population versus the normal population. And it's high. For example, in adolescent, in normal population, 1 out of 5 has a mental health problem. So that means our population, it's even higher. And then you have to look at this through the developmental stages and so on, of course. So then, psychological issues should be viewed as a continuum rather than existing only when clinical criteria are met. Because often, as clinicians, we want to be black and white. This is a clinical depression, not clinical depression. That's a big scale in between. And a lot of talking and doing minor intervention beforehand or addressing this can prevent a clinical impact, so we don't have severe impact on everyday functioning. For example, the example I gave with the individual with a lip scar that isolates them in depression. If we had intervened before in a clinic, talked about them, teaching them social skills, how to interact and work, and that's not difficult, that would have been prevented. And again, you don't need to be a clinical psychologist. You can be a speech therapist, you can be an orthodontist talking to them. Do you know when you go out with your friend, how do you interact? And so on. And that's, I think, where SmileTrain really have the opportunity to put this forward and develop. It will be preventive measures. And this leads us then to how do we manage expectations versus reality? And that is also our clinicians, our expectations versus reality, as well as the families and the patient. So the question is, what I now will focus on is, what can you do in your clinical setting? What bits can you walk away and think about when you go through the remaining of these 2 days of fantastic lecture to keep this component in about the psychosocial aspect and how can we approach this? So it's about understanding. Ensure clinician, you guys, and patient share the same expectation of the outcome. That's essential. If you remember the patient quotes I wrote to you, there was a mismatch of expectations. Parents and children may have different expectations and views of a treatment. You need to encourage agreement. And you need to, don't say question, do you understand what we're going to do? But just a yes question. You need to ask them, can you explain what this will happen? And how do you feel about it? What do you expect? They need to give a full sentence answer back to you. Timing of treatment. Medical needs and the individual psychosocial and practical need has to be taken into account equally. If you have a teenager, you're planning a major operation or something that is about prom night or with other big things, of course they will not be motivated, perhaps. And they need to feel listened to. Because we all know how it feels. So somebody listens to you, you feel appreciated. It's the same for our patients. And I'm certain the majority of you are really good at this already, but it's worth repeating. And then focus on functional outcomes rather than aesthetic outcomes. So instead of saying, I'm going to make your nose more beautiful, no, your nose is going to be more straighter. We're going to reduce the scar a little bit more, or we're going to change. Focus functionality, take away the aesthetic aspect of it. Don't fall in to the trap of our focused, or appearance-focused society. And proper informed consents, dealing with questions such as, why do I need that treatment? They should know that. What happens if I don't have a treatment? What may go wrong? In some cases, health outcomes are often unpredictable. And how long will a positive effect last? Do I need to come back eventually? And so on. So then there are 5 questions to consider when you talk to them to identify a little bit about the psychosocial aspect. Do you worry a lot about the way you look and wish you can think about it less? We can ask this question to ourselves, actually. What specific concerns do you have about your appearance? In some cases, it might not be their lip. We did one study in Australia. The biggest concern for the adults was they were overweight, and nothing to do with a visible scar. Or some men answered, it's actually, I'm losing my hair. That was more. So we need to ask and talk about that. On a typical day, how many hours a day is it on your mind? If it's more than 1 hour a day, it is excessive. And ask what effect does it have on your life? Friends, family, school, or work? And when you ask these questions, you also generate rapport with them. They feel heard. You care in a way. It's not just about that. And I know a lot of you here, you do these questions. But take into consideration, I can actually use this very simple and learn and identify. And does it make it hard to do your work or be with friends? For example, do they isolate themselves because they're bullied? They don't know how to deal with it, and so on. But we need to ask these questions. So, do reassure them that concerns about appearance is commonplace. We all have it. It's natural. But we need to address it. Offer them a chance to talk about their concerns with you or someone with specialist knowledge or skill. Some of you might think, we don't have a time to do this in a clinic. It's busy. But consider, if you talk with them, you can break a chain of negative thoughts that might, in a couple of years, prevent them to having anxiety problem or depression problems. These small talks are essential. What you definitely should not do is pass judgment on their appearance. No, you look fine to me. Don't worry about it. If you say that, you don't validate their subjective feelings because they feel, I'm not looking good. So you haven't listened to me, or you don't understand me. Or say that lots of other people look worse than they do. No, again, it's the subjective how they feel. Therefore, it's so important that all your members in your team are trained in this. Could just be that the reception says something like that, out of kindness. No, don't worry, I've seen more people looking worse than you. But that will then generate a negative aspect for the whole team because the person will lose trust. But can I talk about my appearance issue then? Maybe I'm vain. You know, we need to create that climate and suggest they are silly or making fuss about nothing. No, for them it's very important. So through this speech now, you know what body image is. You know of some of the possible psychosocial impact on our patients. You understand about the risk of stigmatization. And you know that it's the subjective rating, how the patient feel about themselves. Not how you view them. It is their predictive, their subjective feelings that generates the best outcome. And that's where we can help and monitor them. And you know now what to say, what question to ask, and what not to say. So I say muchas gracias. Thank you so much. And it's been a pleasure giving this talk to you. Thank you.
Wonderful. Thank you, Martin. As a surgeon, again, we think in black and white, but there's so many more dimensions to the children. And I think now would be a great time to, if anybody has any questions.
Las preguntas abiertas, the open questions. My concern is we work with children, teens, and adults. It's a very long step to go. When can you address a child with such an open question? Maybe he doesn't have the problem, and with your question or with your open clinical question, you will create a problem in that child.
So this is quite a common question for you, if when do we address it? Or if we ask it, it might generate a problem. And that is, A, is about ages when you start asking it, and so on. And that is about the developmental stage when you feel it right. Around 8 or 10, we're quite self-aware. We know 5-year-olds know what is good or ugly and how they view themselves. So this comes from a various stage. And you can ask more questions about, do you get bullied? Does somebody comment on your appearance? How is your school? Ask, do you have friends? What do you do after school? Those answers are neutral, but will also generate you an indication. And it's quite common when we talk about the psychosocial aspect, but what if I cause more problem? We don't. In many cases, they feel acknowledged. And you can explain, why do you ask if they're feeling good? Well, some people get very bullied because of appearance. Apparently, you're not one of them. You have strong resources, which is great, you know. So you can build them from that, this building. And also by having this conversation currently throughout, it makes it open, because stages changes. So soon we transition to another school. You have child that shift schools, and that's the general population. We come into the wrong crowd and get bullied. If we've gone to another school, they might have met perfect friends and never been bullied. So therefore, it's very open to have this discussion. But you will not harm anyone to asking about them. What you can say, if he asks you, you explain why. And it's about creating an openness about it. So it's a very good question, because I think a lot of people thought the same here. Any more questions? Yes.
Hello, good morning. Well, you talked about the informed consent. We are very used to give information to the adults and not to children. Maybe to adolescents, we are more open to give information. Any suggestions for the clinical team about that issue? When, how to do it, how to give information for kids, and why is it so important to give that information?
So when talking about the younger children, they are receiving your treatment, your excellent treatment, and they need to feel involved. There are studies that shown that they felt left out. It was just my parents and the clinicians that talked. I had no say. I just went along. As longer they went up, they start and say, I don't want more treatment, for example. But part of that is normal rebellion when you're growing up. You've never been involved in something. You want to find your own self-autonomy. By involving them, feeling they're a part, you empower them and take away some of the scariness in it. And we've seen this in a lot of qualitative interviews, like the quotes, there hasn't been enough information, understanding. And it is, you need to have them reply back to you. Explain it in your own words. Explain, what is it you expect from the surgery? Do you understand what will happen when you wake up from anesthesia? And so on. By that, you take a lot of stuff down, or you identify, oh, we don't really understand. We need to spend a little bit more time. And that time is so well invested for the psychosocial health. It's invested for the parents, because sometimes the parents didn't realize how much what would happen afterwards and so on. So it is about the communication is the biggest thing. And it is important. You do all the safety procedures for surgery. Don't forget that component about the consent. It's so important to make them feel part of it. Yes, very deep questions here, early morning.
Thank you, Martin.
Okay.
Thank you, Martin.
Thank you so much.